So GERD, all right, so gastroesophageal reflux disease, again, there's a lot of overlap with hiatal hernia, okay? So hiatal hernia promotes GERD, but you can have them, and you don't have to always have GERD with hiatal hernia, right? Hiatal hernia can lay the foundation for it, but a lot of similar causes and symptoms, right? So here is our, over here we got our hiatal hernia up top, right, there it is. Sorry, hiatal hernia that can relax and cause the brashing of fluid is the official medical term. So usually the sphincter is closed, right? But the sphincter can weaken because of all the things we just mentioned, right? All those things we taught a patient with hiatal hernias are the same things we're going to teach for GERD, okay? And then if we keep brashing up against that esophagus, you're going to erode it, and you can eventually, the esophagus is like, fine, I'm going to make stomach cells now, right? So it goes from squamous cells to stratified columnar cells. That's called dysplasia, where you start making different cells than you're supposed to, and that can lay the groundwork for cancer. Okay, so as we'll find out, chronic inflammation or chronic irritation causes every cancer. All right, so if you have chronic inflammation, you're a certain area, you're likely to get cancer of that area, right? So, for instance, if you have ulcerative colitis, that we'll talk about later, which is a ulceration of your colon, you're at high risk for colon cancer, right? You have a lot of ulceration of your stomach, you're at high risk for gastric cancer. Ulceration of our esophagus, you're at risk for esophageal cancer. And there's certain chemicals out there that will irritate it directly, like tobacco and alcohol, right? All right, so overview of GERD, all right? So it's chronic, all right? So they have to be losing the weight, they have to be cutting out the different things that stimulate GERD, all right? So it can cause tissue damage, leading to a risk of cancer. It's the most common disease of Western man, all right? So one, because of obesity, but also because of our lifestyle choices and what we choose to eat, all right? So the symptoms of GERD are often extraesophageal. What does extraesophageal mean? Outside of the esophagus, like extraterrestrials outside of the terrestrial, all right, outside of Earth. So extraesophageal means we have symptoms that are outside the esophagus. We're still going to have the esophageal symptoms like what we had with hiatal hernia, but one of the differences between hiatal hernia and GERD is that hiatal hernia has shortness of breath and GERD symptoms, but GERD has GERD symptoms, but GERD also has extraesophageal symptoms, symptoms that you would not get with hiatal hernia, okay? So, for instance, this acid can make its way via that weak lower esophageal sphincter into the next tube over. What's the next tube over? Into the trachea, right? It goes up the esophagus and over into the trachea. It can cause pulmonary fibrosis and asthma and a chronic cough. It can cause damage to your respiratory system. Okay? So what else? So we got, again, we mentioned that the cells can start changing shape, right? And that's technically, when they change shape, that's technically called Barrett's esophagus. So Barrett's esophagus is an important middle of the road that you need to fix your ways, because Barrett's esophagus can transition to cancer, all right? And how do you get cancer? From chronic inflammation, chronic irritation will cause it, all right? So GERD is very, very popular. And notice where GERD is most popular is when it's dark red over here in Saudi Arabia. I'm not sure if they're okay, but Saudi Arabia has a lot of GERD. What country is this? Is that Poland? What is that? Anyways, Eastern Europe has a lot of GERD, right? America is about 20-25% of us have GERD. And then Canada, are you okay? Canada, they have almost 30-35% of their population has GERD, all right? Notice who doesn't have GERD as much. They're in the yellow, they're 15%. That is India, right? So as you'll find out, the common, as you study your book and study other things, they'll say spicy foods. Spicy foods cause GERD, cause dyspepsia. It's like, no, it doesn't. It's actually a treatment. A treatment for erosion is you give capsaicin to fix the inflammation, right? So it's in India, food is an extra kind of spice, right? I can do Mexican spicy, I can't do Indian spicy, right? It's a whole nother window into spiciness, right? And these guys are spicing up everything, right? They're like, you want level 1? Sure, level 1. And I can't survive, right? Level 1. It's like, give me more doll. Anyways, so these guys have, spicy food is not the reason for GERD. What is? Stuffed jalapeno poppers, right? What are they stuffed with? Cheese. And cheese is dairy, is also fat, and it's also going to relax the lower esophageal sphincter, right? And then the spicy food's gonna come behind. Oh, see, it was a spicy food right there. It's like, I think there was something else when you dipped it in ranch. That was also what caused it to weaken. All right, so pathophys, what's going on? So we have a lower esophageal sphincter again. All right, it's getting weak. All right, so here's GERD right now. Right, you got all that lava in your stomach, and it's like, yeah, right? So it's going up, and it's going to erode the esophagus, all that lava from your stomach, because that lava is what? The gastric juices, right, with a pH of 2, right? What's a normal pH of GI contents? Like 5 to 7, somewhere, you know, not blood pH like 7.35, 7.45, but it's more basic, right? So, but that low acidity is going to cause damage, right? We got a weakened LES, right? It can be transient. They put a T in front of it, transient lower esophageal sphincter relaxation. Cool. All right. Either way, you have increased intra-abdominal pressure, and as we mentioned before, just for copy and pasting, the same thing. There's nothing different here. Okay. What is actually going to point out what is different? We got hypotension is also on the list. So we got hypotension can cause erosion of the stomach and erosion of the esophagus because you have low blood flow to your GI tract, right? You can't take away the acid that was delivered there by all this acid right there. That acid has to get reabsorbed in the bloodstream and it gets cycled away, right? If it doesn't get, you know, swallowed, if you don't, you know, drink a glass of water or something, but that acid is going to get reabsorbed, right? If you have low blood pressure, you can't reabsorb that acid, so the acid stays there for longer. Okay, so this happens with patients with severe disease or ICU patients. So ICU patients often are on a medication that's going to lower the pH of their stomach. What medication is that? What is it? Protonix is the brand name. What's the official name? Pantoprazole, all right? So pantoprazole, which is a PPI, a proton pump inhibitor. It's going to inhibit the protons. And what's a proton chemical? It's behind Adelina here on the periodic table. Has one positive charge, hydrogen ions, right? So hydrogen ions it's a proton pump inhibitor. It's inhibiting the proton hydrogen, right? Anyways, so relaxes the LES is relaxing inappropriately, right? Is spicy food doing it? No, it's not, right? All right, so anyways, the reflux material is going to make its way up, and it's going to linger and irritate that lower esophagus and cause symptoms, okay? So you can also have another reason that you could have get GERD symptoms is what if, again, for the like reverse problem of the ICU are hypotensive and you can't take away the acid fast enough so it burns. But what if you can't get the acid or get a high acidity meal down into the stomach, right? What if you're drinking, don't drink bleach, but what if you're drinking something caustic or acidic and you have what's called achalasia? Achalasia is difficulty of movement of the esophagus. All right, or you have dysphagia, you have something that's in the way, making it difficult for food to get on down into the stomach. You're going to be exposed to those caustic materials for longer than you would normally. Okay, so it can cause scarring and dysplasia, and we have dysplasia that's called what? Barrett's esophagus. All right, that puts you at risk for esophageal cancer. 1 in 1,000. It's like I like those odds. Those aren't great odds. 1 in 1,000. Okay. All right, so what else? So we have this reflux of gastric acid, but sometimes, so all this acid make its way up and it's breaking apart the skin or the squamous cells that are inside that esophagus, and they can convert to Barrett's, right? So we talked about hiatal hernia can put you at risk for this, right? We can have acid clearance being not great. That's with the achalasia piece. We got the lower esophageal sphincter relaxing inappropriately. And just to recap, we have foods, so we're going to cross off spicy foods, right? But we have different foods and beverages and different medications. These are all the same medication before. And also, what kind of gum relaxes your lower esophageal sphincter? Peppermint does. Spearmint does a little bit, but peppermint for surezies. Okay? So also medications themselves. Medications can be toxic, right, or acidic, right? Like acetylsalicylic. Was it acetylsalicylic acid, right? Is that am I saying it right? Salicylic, there it is. Acetylsalicylic acid is also known as aspirin, all right? So it has an acid in it, right? So that acid itself can damage the lining of the stomach, right? Also, NSAIDs are a common reason to get GERD and get ulceration as a result of GERD. So NSAIDs are on the list here as a medication that will damage your stomach lining itself. And we'll come to find out that NSAIDs will also actually work internally behind the scenes and actually disrupt and cause more acidic damage. So we'll talk about that shortly. Right? Iron does, potassium chloride. They always have to drink it with food. Right? You say, here, have some orange juice. Oh, acid on top of acid, that's great. All right, but you have so these foods, basically, these are medications to take with foods, right? Because these medications cause acidity, right? Or sorry, are directly toxic to the gastric lining, right? So you can memorize all the list of medications that have you take with food, or you can memorize the ones that are damaging to your stomach lining. Some have to be absorbed with fats, so they want to make sure you're having a little food bolus. But for the most part, it's a medication, your patient's going to start complaining of GI upset, right? Because every right answer for your drug guide, it's like, what medication are you giving? I'm giving this medication. What are the side effects? Got GI upset, some nausea, vomiting, I get a headache. All right, yes, that is also true for any medication. These ones especially are going to start to cause some GI upset. Okay? All right, so risk factors we mentioned before, alcohol, smoking, high-fat diet, these are all going to cause a relaxation of that lower esophageal sphincter. All right, so symptoms of GERD. Number one symptom reported is heartburn. You got dyspepsia is the fancy name for that, right? You get atypical chest pain, which we'll talk about in the next slide, or what cardiac chest pain looks like versus GI chest pain. But they might get some complain of some chest pain, and they describe to you like, I just had a big fatty meal, and I'm chewing on some spearmint gum right now, and I just had a little coffee, and I chased it with a little bit of vodka on my coffee too. Well, I think I know what the problem is, all right? But we'll do an EKG just in case, worst case scenario, right? To see if there isn't any kind of cardiac issues, right? So we got esophageal spasm due to those acidic contents. If you get acidic contents on you, you're going to wince as well. So your esophagus winces too. All right, so it can last about 2 hours. It can radiate a little bit to the neck. All right, you get more pain while you're supine. Why do you get more pain while you're supine? Because the gravity will help it leave the esophagus. So if we are supine, it's going to cause more damage, cause more symptoms, right? And if you're bending over, right, now all that juice is going to make its way up the esophagus, right? Performing the Valsalva will create a negative pressure in the chest, drawing that acidic content upwards as well. All right, that acidic contents can make its way all the way up to the mouth and cause dental caries. Right? Does hiatal hernia cause dental caries? No. Right? Maybe if you get GERD because of hiatal hernia and then it causes dental caries, but GERD itself is causing those dental caries. Right? And also these guys are not going to be left out. They also have globus to share. Right? So they're going to not upchuck was what I'm looking for. They're going to have globus that they're going to be producing as well. All right, GI contents in the throat. Right, and all these things can get aspirated. And aspirated means it's going down the wrong tube. Right, so they can get an aspiration pneumonia. They develop a pneumonia-like symptoms, and especially they get it at night when they're not awake. Right, and they might not be sleeping correctly. And how should they sleep? On their left side or right side? On their left side. All right, for extra credit, they should be in what angle? At 30 degrees at least, right? And they can develop a chronic cough that they develop because of their that chronic aspiration of acid. We mentioned they get pulmonary fibrosis, they get adult onset asthma, right? They never had asthma before, they don't have any allergies, I'm fine, what happened? And it's because of their GERD that might have led to it, okay? They have wheezing on auscultation, all right? It is a sign of poorly controlled GERD. All right, they got a morning hoarse voice, all right? So they have a hoarseness in the morning. They can have a laryngitis, pharyngitis. They have a deep voice. Their voice changes over time, and they can even have bronchitis as develop COPD because of all this. Okay, so the key thing here though is those are all symptoms of GERD, and we want to recognize those, but we also want to recognize signs of esophageal cancer. So esophageal cancer is the worst case scenario, one of the worst complications. A GI bleed is also bad, but these complications here are not good. They have weight loss. It's unintended, right? They come to you and they say, I don't exercise at all. What are you talking about? It's like, well, how are you losing weight? Well, this unintended weight loss is a classic sign of cancer. Okay, so classic sign of cancer is unintended weight loss. So you're losing weight without even trying. All right, you have signs of GI bleeding. So signs of GI bleeding are what? What are they going to present with? So they could have hematemesis if it's a profound GI bleed. They might just have some coffee ground emesis. They also might report what findings in the toilet? Some black tarry stool. Probably not hematochezia unless they really ulcerated and destroyed some of their vessels. Okay, so hematemesis, and if it's over time, they might not get coffee ground emesis. They might not be able to see it because that little black tarry stool is so small and it's mixed with all the brown stool. They might not be able to see it, so they'll feel weak and fatigued and anemic over time. And we talk about anemia for the second exam. We'll come back to this, right? But they get iron deficiency anemia from losing iron. And where is iron found in? In RBCs, right? What part of the RBC is made of iron? The hemoglobin. Okay. So they get dysphagia. Well, they might have trouble swallowing that got them GERD in the first place, but here you have a cancer, you have a tumor that's occluding the opening, right? It's making it difficult. So right down here we got scar tissue of that esophagus, and it can cause changes in the esophagus to make it difficult to swallow, but also it could be a tumor, right? Remember, all that acid can cause contractility of that muscle, and that muscle can get tighter and tighter and tighter, and it gets strictured, right? So it gets narrowed and develops a stricture. And we can fix that with an EGD, right? Remember, EGDs are diagnostic, but they also can intervene. So you can go in there and just blow it up, right? And blow up a balloon, right? Right, they don't use their mouth, they use a little device. All right, so then also they can use they can put a stent in there afterwards. So they put a little stent in to keep it open, okay? But worst case scenario, it could be a tumor, and a balloon and a stent wouldn't work great, okay? So these are alarm symptoms that we have to recognize, and these alarm symptoms we can carry over to all the cancers, especially the GI cancers, right? Because when you have a brain cancer, you're not going to get a GI bleed, right? But if you have a colon cancer, you might get a GI bleed because that tumor is going to erode into the vessels and it's going to cause bleeding. A tumor of the gastrum or the stomach is going to erode into the gastric lining and it can cause bleeding. Here, the esophagus can get eroded away and cause bleeding. Okay, so dysphagia, especially if it's progressive, like the last 3 months, has been really difficult to swallow. So they could have just, best case scenario, they just have the acid causing strictures, or the acid's causing a ring shape at the bottom of the esophagus. It's called a Tchotchke ring. Okay, I have one of those. It's called a fidget spinner. Anyway, it's got odynophagia. All right, so dysphagia versus odynophagia. What's the difference? Dysphagia is trouble swallowing or difficulty swallowing, and odynophagia is ouchy swallowing with an O. All right, so it hurts to swallow. One is just difficult to swallow, one it hurts to swallow. Which one hurts? Odynophagia. Okay. So and then also there could be ulcerations that are there. It could be, again, they could have nerve endings that are being exposed. So long-lasting GERD, this is where you have GERD you tried all the medications that are available to you, and you still have GERD. That could be a warning sign that you might have ulceration, not just from the acid, but ulceration from the tumor itself, right? Anytime someone gets GERD over the age of 55, that's a problem. You shouldn't have new onset GERD as an elderly person, all right? So they have to investigate to make sure it's not worst case scenario, esophageal cancer. Okay, so we teach alarm symptoms to the patient, right? Is he feeling fatigued? Are you feeling difficulty swallowing? Over a progressive amount of time, you report any kind of, you tell him hematochezia, or you tell him what? You probably wouldn't have hematochezia unless it's a huge bleed. They'd probably teach him, make sure you don't have any coffee ground emesis, or what's the black tarry stools called? Melena, right? All right, what else? So head of bed elevation, left side, small meals, all the things we're going to copy and paste what we learned for the hiatal hernia to here. Okay, so here's the difference between hiatal hernia versus GERD, right? Which one has extraesophageal symptoms? GERD does. Did I even put it there? Yeah. So extraesophageal symptoms, such as what? Things that happen because of aspiration, right? Such as they got aspiration pneumonia, they have a chronic cough, they develop asthma. These are extraesophageal symptoms. And yes, asthma causes shortness of breath, but which one primarily has shortness of breath? That's hiatal hernia. Okay. And this little flow chart here should make sense. We talked about all the different things that can cause a progression to GERD. GI chest pain versus cardiac chest pain, right? So GI chest pain is really important because we can recognize if someone has GERD or hiatal hernia or whatever it may be. But which one's more life-threatening is our cardiac chest pain, right? Even an MI is not worst case scenario. What's a worst case scenario of cardiac chest pain? What's that? Ischemia? Yeah, aortic aneurysm is pretty bad, right? You're bleeding out and you have chest pain, right? Usually that pain will radiate to the back with aortic dissection, right? But MI is pretty bad, probably second, third place, right? We got a MI on our hands. We got cardiac chest pain. We have that's why usually everybody gets an EKG and an echo if someone complains of chest pain and they're being admitted to the hospital, right? But everybody goes, when it comes to ER with chest pain, they get a EKG automatically to make sure it's not a MI. An aortic dissection is not going to show up on an EKG, but it might show up on an X-ray, right? Or an echo if you're fancy. Okay. Anyways, a MI is sudden in onset. Usually someone has GI pain. It's been gnawing at them for a while. It's associated with meals. It's not something that's going to happen all of a sudden, right? Also, a cardiac chest pain usually radiates, and yes, there can be some radiation with GI chest pain, but usually a MI is going to radiate, right? It's going to be substernal versus subxiphoidal. So subxiphoid is usually the epigastric area, and that's where you have like a peptic ulcer disease or GERD starting. All right, and then we got pressure. So they're describing pressure to you. It's not burning or gnawing or sharp. It is pressure, like an elephant on the chest, right? Those are signs of cardiac chest pain, right? If it's burning, I mean, it could be pericarditis, right? Pericarditis also, those guys just came from Med-Surg 1. What does pericarditis have a symptom of? What's that? EKG changes, but what about chest pain wise?
Pain with position.
Good, positional. So it's positional chest pain. As they lay backwards, all the contents of the thorax lay on that pericardium and cause pain, right? So they have supine chest pain. So when someone has a heart attack, it doesn't matter what position you're in, that chest pain is always there, right? So that's what describes cardiac chest pain. We want an EKG and echo to make sure that we don't have something worst case scenario on our hands. Right? Respiratory-wise, right? Also, sudden onset could be a PE. PE causes chest pain. Pneumothorax causes chest pain, but usually these things are all of a sudden. Okay? Pneumonia usually takes a while to build up, but usually someone does not desaturate when they have GERD, right? So that's a one way to clue. If someone's on like 4 liters of oxygen, they're on 10 liters, and they're really feeling some chest pain, it probably isn't GERD at that point, right? So GI is usually non-radiating. There can be other versions that do. It's non-tender, right? It doesn't hurt when I touch it, right? Like costochondritis, that's a coughing too much or a sprained rib, right? That hurts with position, right? So this is what's with GERD, you're not going to get those symptoms. It's not, when I touch here, does it hurt? No, GERD, it happens within the esophagus, right? It's within a tube. So it's the tube that's inside of, I don't have a good picture here, but you can't touch the esophagus externally, right? You might be able to touch the stomach, but it's not going to really cause, you're not going to be able to cause the pain. The pain is like nerve endings being acidified, right? But what kind of abdominal pain can you palpate is peritonitis, inflammation of the peritoneum, right? Because the peritoneum goes where? It goes around every single organ. So the liver is kind of like that. There's the stomach like that. There's you can say each small intestine and large intestine is wrapped up, right? So if you have a ruptured bowel, a bowel that has perforated, that has a hole in it, all those GI contents are going to spill outwards and cause inflammation. Well, when you touch this just a little bit, it's going to hurt a lot, right? So peritonitis is actually very, very painful. They have not even rebound tenderness almost. It's just tender to touch. They have a rigid board-like abdomen that's very, very painful. Okay, so GERD and PUD, right? They're not going to be really abdominal. They're going to be relegated to the epigastrum. But when we talk about different kinds of abdominal pains later, certain abdominal pains are in certain quadrants, right? When you have left lower quadrant pain, what anatomical structure is there? The what? What structure is in the left lower quadrant? The sigmoid, right? And as we'll find out, diverticulitis, diverticulosis is not painful, but diverticulitis is going to be and that's usually affects the sigmoid colon. So we're going to find it right there. All right, appendicitis is in which quadrant? The right lower quadrant, right? And we'll talk about pancreatitis next week. And pancreatitis is usually across the epigastrum up top. Okay, so you can see the nerve endings are just all the way around. So when you touch the abdomen, you're going to start causing pain, especially with someone that has peritonitis, has a inflammation of the GI tract or perforation of the GI tract for that matter. All right, so let's take a break and we'll come back with finishing GERD. All right, so we're finishing up GERD diagnostic tests, and then we're going to hit up some treatment for GERD. All right, so EGD, again, every GI case is going to have some kind of scope or something to try to diagnose what it is, because the EGD can intervene and fix something, but it also can diagnose. How does an EGD diagnose? Like visually, they can look at something and see, oh, look at that. That looks like an ulcer. Or what else can they do? They can biopsy. They can take a piece of it and see if it's stratified squamous epithelia or columnar epithelia. They can identify it and see if it's cancerous or not, for instance. So for GERD, they're looking for erosion, right? So see this erosive esophagitis and ulceration from all this acid brashing up against the esophagus, right? So esophageal manometry, we mentioned, is where they can just assess the swallowing of the patient right there in the lab. But also they can do what's called a ambulatory manometry and pH monitoring, where they're going to monitor the pressure and monitor the pH over 24 hours. And it says like how long were you supine or recumbent, when did you have heartburn, when you have belching. So they on their app or whatever, they're going to input that data so the doctor can then interpret this and determine if they have GERD or not. Okay, but usually symptoms is pretty much going to tell you if someone has GERD or not. But they want to make sure it's not something like if it's been long-standing, that like for instance we said someone that has age greater than 55 that has GERD symptoms, we want to make sure we assess it's not cancer, because that's one of our what kind of symptoms? One of our alarm symptoms, right? So the EGD can also open up and fix a patient that might have fixed causes of GERD. Okay, if they have like achalasia or difficulty swallowing, and like the acids or medications are causing erosion, right? There's like they call it a Tchotchke ring, where the acid is made narrowing of the esophagus, so therefore they went in with a balloon and opened it up. All right, so treatments. So lifestyle changes is a big one. So weight loss and exercise, you can say that for every disease process. It also applies here because of what does increased weight do? Because increased abdominal pressure, right? Head of bed, that's going to also alleviate the abdominal pressure, but also is going to cause less acid from making its way upward, right? And then pharmacological, right? So we have medications that will neutralize the pH, so the pH is not so acidic and not so damaging to the stomach, to the esophageal lining. But we can do that with antacids, right? We can do that with reducing the acid production altogether. So antacids neutralize the acid that's already there in the stomach, whereas something like Protonix, pantoprazole, or an H2RA, they all will inhibit the production of acid from the cells themselves that produce acid. And what cell produces acid in the stomach? Which one? Parietal cells. Or I heard the end of it. I don't know. But parietal cells. Those guys produce hydrochloric acid, right? And it's through a proton pump. Yes.
Does this affect digestion in any way, since you're reducing the acid in the stomach?
Good. Yeah, you can. You have what are called zymogens. You have different protein enzymes that break down proteins in your pancreas, right? Your pancreas releases trypsin, right? And that will make its way down the biliary tract or the common bile duct into the duodenum and break down proteins there. So as far as like a malnutrition point of view, no, right? But good point with acidity is needed to break down other things, right? Not just proteins, right? Our pancreas has the stomach's back, and it will break down proteins and nutrients. But what the pancreas does not have is acid, right? You need acid to cleave intrinsic factor. And what is intrinsic factor for? Whoever remembers physiology? for B12, right? So they could be B12 deficient anemia, right? They can have B12 deficiency anemia with like Protonics use, for instance, right? Why Protonic or pantoprazole versus a H2RA, right? Because these are our main two ones, H2RAs and PPIs. Well, because PPIs are like, they really work at the central location of hydrochloric acid production. They're like 80 to 90% effective. They are really going to turn down for what? No, they're going to open. They're going to raise the pH. All right. So cimetidine, it only works like there's like 3 or 4 different things that will release hydrochloric acid. Right, and then one of those things being histamine, right? So histamine binds to histamine 2 receptors. So we have histamine 2 receptor antagonists that will stop the production of acid. Acetylcholine will do it, will release acid. What is it called? Prostaglandins will actually inhibit acid. And there's some other things that will stimulate acid production. So we have many different things. The H2RAs are not as effective as PPIs because PPIs are going right to the source. Okay, so yeah, so we're going to neutralize the acid with antacids, and we're going to reduce acid production. Okay, you'll notice we got this chart down here is kind of how you want to handle your medications. So this chart up here on the board is how you want to handle disease processes and complications. But as far as like medications, you want to kind of handle like this. You want to have the class, because usually the class will tell you, usually they have the same last name, right? Some classes don't, and they've been kicked out of the club. But otherwise, most classes do have the same last names, like beta blockers all end in LOL, right? And all PPIs, proton pump inhibitors, end in what? Prazole, right? All H2RAs end in, tadine, right? So they all end in tadine, right? Ranitidine is actually died with COVID. It got COVID and it died. All right, the FDA took it off the shelf in 2020, and nobody paid attention to it. Anyways, it's gone. So, but the other ones are still around. Okay, and then we got antacids, which we'll talk about in the next coming slides as well. Okay, and then what else? The last one there is prokinetics. Prokinetics are not given really for GERD unless the GERD is caused by hiatal hernia, right? But usually that's kind of just relegated to hiatal hernia alone. Okay. All right. So lifestyle modifications, pharmacological, and then we got surgical. So we'll take a detour to pharmacological in the next couple slides. But surgical fixes for GERD, right? So they have a weak esophagus, a weak lower esophageal sphincter. They can go in there. They can do what's called a strata procedure. That's a radio frequency ablation. They're going to go in there and hit it up with some energy waves, like 102.6 FM, all right? And they're going to then make it tight, all right? It's literally a vaginal rejuvenation for the esophagus, all right? It's going to tighten it up, okay? And then we have the LNF, the Nissan, right? So laparoscopic Nissan fundoplication. That works too, right? It's going to tighten up the esophagus, make it less weak, okay? What else? We got endoluminal. That means they use the endoscope and they just pull it with a little candy cane. They pull all the stuff from within the stomach and then suture it up and staple it. So they can do it that way as well. All right. So those are our surgical fixes, lifestyle modifications, and then we're going to dive a little bit deep into the pharmacological. So this table is an overview of all the pharmacological stuff. So we're just going to try to help you explain and get to the right answer every time. It's like, how do I know it causes osteoporosis? Well, we're going to try to explain it. I'm not going to ask you on the test what causes low calcium and pantoprazole with pantoprazole use, right? I'm going to ask you, pantoprazole has which one of these side effects? And you're going to get the low calcium because you know the reason why, right? So you're going to know the reason why I have head of bed elevated, right? Do I have head of bed elevated or supine? Which one was it? So the idea behind lecture and theory is to know the theory behind everything and how it works, right? That's the whole idea of this class. Otherwise, I could just say, here's your general causes, 15%, right? Here's the symptoms, here they are, here's all 30 of them, right? Here's your complications, and here's your nurse interventions. All right, we good? We're going to flip a classroom now. No kidding. All right, so we're going to... So that's the idea behind lecture, or that's my idea. All right, so we're going to go into the reason why H2RAs are less effective than Protonics or than pantoprazole. Why antacids cause some of them cause diarrhea, and some of the other ones don't. All right, so antacids. So there's really like 4 antacids out there. All right, they're in orange. All right, so we have what's the mechanism of action? What are they doing? Are they reducing hydrochloric acid or neutralizing hydrochloric acid? So they're neutralizing it. So they're neutralizing the hydrogen ions in the stomach, right? This is going back to basic chemistry. You got a H plus, we got to attach a negative to it, right? So basically when these antacids hit the stomach, they're going to break apart, and their negative component is going to bind to the H component, and the power of H is called pH, right? So you're going to neutralize those hydrogen ions, right? With an HCO3 negative, a CO3 2 negative, which is a carbonate, bicarbonate, carbonate, OH negative is a hydroxide, and O2 negative, right? So all those things are going to, that's an oxide. All those things are going to neutralize the hydrogen ions that are inside the stomach and raise the pH or lower the pH. Which one? It's going to raise the pH, right? All right, so examples of antacids. So we have ones that are absorbable. That means when you give this antacid, it not only neutralizes the pH, but it also a component of it gets absorbed. And that would be sodium bicarb, right? So sodium bicarb, which is Alka-Seltzer, when you give it, the sodium is going to bind to the bicarb is going to bind to the hydrogen, but the excess amount of bicarb is going to get absorbed by the bloodstream, and you can actually get metabolic alkalosis because of this, all right? So the other ones are non-absorbable. And also another point there is when you change the pH of the stomach, these medications were designed to get absorbed in a pH of 2 to 4. Like warfarin, for instance, digoxin, they need to get absorbed in an acidic environment. They've broken down a little bit and get absorbed. So you can impair different drug pharmacokinetics when you mess with the pH of the stomach. All right, so we got calcium carbonate, that's Tums. All right, so the carbonate's going to bind with the hydrogen ion, and it's going to neutralize. It does not get absorbed, right? So maybe a little bit of calcium might get absorbed. So a renal failure patient, it might work a little nice. Aluminum and magnesium, those ones maybe a little bit might get absorbed, but for the most part, they're not. Okay. So aluminum, so the aluminum hydroxide, aluminum and magnesium. One of them causes constipation, one of them doesn't. So aluminum definitely causes constipation. So aluminum is going to bind as like a metal. Figure if you eat tinfoil, you're going to get constipated maybe. I don't know how you remember that. But magnesium, though, magnesium citrate is used as a colonoscopy prep. Right? When someone gets a colonoscopy and the GI doctor goes in with the scope, he doesn't want to see what you ate yesterday. Right? He wants to see a nice clean bowel. Right? So he's going to go in there and he's going to want to see everything that he could possibly see so he can intervene, right? So mag citrate, though, is a powerful cathartic, right? Does this work?
I heard this gets rid of a stomachache.
Oh, bless your heart, baby. Well, there's no drinking the stuff back out, so you have about 2.5 minutes to go get your phone charger with the longest cord, a gallon of water, and cancel all your plans for tonight and most of tomorrow, because you're about to relive every regret, every happy memory, and every fear, and even that Flintstones vitamin you had back in 1991, as it all leaves your body, honey, because you're going to be sitting on that porcelain crown for a while, so I hope your cheeks are nice and ready for it. I mean, it's going to fix your tummy all right, but it's like nailing a nail with a sledgehammer. Does it get the job done? Yes, but is it necessarily pleasant? No, honey. Oh, bless your heart.
All right, so mag is really going to be a powerful, not diuretic, but cathartic, right? All right, so that's the idea. So mag, these other pieces are going to bind, and we have aluminum is constipatory, and magnesium is going to make it flow. All right, and then sodium bicarb, right? We mentioned that bicarb binds with citric acid and acetic acid and all the acids and tomatoes and such and cause CO2. So the same thing, sodium bicarb is going to cause some belching or eructations and a lot of farts. All right, what else? Combine aluminum and magnesium can sometimes it's like, well, if we got one causes constipation, one causes diarrhea, why don't we give them together? And that's what Malox is. Malox, so that's a brand name, combines, it's a combo drug. All right, so PPIs and H2RAs. So one of each of these you have to know for your IV push checkoff, right? Which one do you have to know for each? You have to know pantoprazole, right? And what's the H2RA you have to know? Cimetidine, right? So all PPIs end with what suffix? with prozole, right? So the mechanism of action, or the MOA, right? That's one of your columns, right? So what's the class? It's a PPI, and you usually want to do what's the example. This isn't it, but what is the example? Is they all end in prozole, such as pantoprazole, lansoprazole, famotrazole. All these all end in prozole, right? And they all have the same action, right? You don't have to know the nuances between each one. Like one it has a half-life of 6 hours. One has a half-life of 24 hours. You don't have to know that, okay? That's not nursing school related. All right, so anyways, we have mechanism of action is going to inhibit the proton pump. So where's the proton pump? It's the parietal cells right here. Right, so here's a parietal cell. We're going to zoom in, right? And if we zoom in the parietal cell, it's secreting what into the lumen of the stomach? Secreting hydrochloric acid, right? So the proton pump inhibitor actually inhibits right there, right? The PPI is inhibiting the production or the release of hydrochloric acid, right? So you can see it's really working. It goes straight in, like Independence Day. It's going right up the deal. Okay. Anyways, we have that's a good GIF I should put on there. Yeah, for next time. Anyways, we got what else? We got side effects of if we don't have hydrochloric acid in our stomach. Yes, we might have poor absorption of certain medications, but GI upset, okay. But bacterial superinfections. What is a bacterial superinfection? That's an overcolonization of bacteria, because that low pH was actually beneficial to get rid of bacteria. So now we have overgrowth of possible bacteria. And what are some ones that we know about? H. pylori for sure, and C. diff, right? And we'll talk about H. pylori. I have a whole slide dedicated to H. pylori. But C. diff is bad. We got some, you can get pneumonias because Pseudomonas pneumonia or strep pneumoniae, those grow in the stomach too, right? So all those can then make their way up, and then yes, you cause pneumonia, but C. diff makes its way down and causes C. diff colitis, right? Causes the colon to get itis-y. All right. What else? We have you have C. diff associated diarrhea from a medication that's going to raise the pH, right? And this one's going to raise the pH the best, so it has the most association with what's called CDAD, which is C. diff associated diarrhea. Okay. All right, what else? So vitamin B12, we kind of mentioned B12 gets absorbed in the terminal ileum, right? Where's the terminal ileum located? At the end of the ileum, yes. Where's your ileum? Point to your ileum. It's on your right side next to your appendix, right? Right lower quadrant, and that connects into the large intestine, right? It's the last stop before your large intestine, right? Your cecum and your ascending colon. So that's where B12 gets absorbed. B12 does not just appear there. B12 hitches a ride with intrinsic factor, and intrinsic factor gets activated or separated by low pH. So if we have a raise of pH, we don't have intrinsic factor that can work with B12, and then B12 doesn't get absorbed, right? And we'll talk more about B12 with anemias for the second exam, but this kind of relates to that, right? And then osteoporosis is also exam 2, but you have osteoclasts, which are inflammatory and are breaking things down. They're not great things to be activating, right? So that's what causes osteoporosis and such. So if we have osteoclasts being activated by one of the metabolites of Protonics, you're going to get a risk for bone fractures, right? And then low MAG, so it's interfering with nephron function. So the metabolite, again, is interfering in the kidneys, and it's inhibiting MAG reabsorption. So we get low MAG as well. All right, so those are side effects of pantoprazole and all prazoles, right? You want to take this before meals, so that way you don't get the GERD symptoms, right? It takes about 50 to 30 minutes to kick in. It's longer lasting, it's more effective, but 90% of your acid is blocked, right? Acid production is blocked. And you should be supplementing calcium and mag because it's low. It's going to be low with this medication if they're on long-term use, right? And then we have H2RAs. So H2RAs, they all end in what suffix? Entidine. Their side effects are very minimal because you look where they work. Remember, you can just stop the factory altogether with the PPI, or you have other things like acetylcholine. When it's in the vagus nerve releases acetylcholine, and it will cause more acid production, right? You have gastrin, right? Gastrin is a response to proteins in the stomach, and gastrin will cause a hydrochloric acid to be released. And then we have histamine, which gets released because of the vagus nerve also, but histamine is going to get released, and then it's going to bind to the parietal cell, causing hydrochloric acid production. So we give it H2RA. Is it an agonist or antagonist? antagonist is stopping histamine from working on that stomach. It's not an H1RA, otherwise it would be like for allergies and such. It's an H2RA. You have histamine 2 receptors along your GI tract. All right, so H2RAs are going to cause a reduction in acid, but not as great as pantoprazole. Okay, it is rare. You always see all kinds of questions that, someone's on cimetidine and they're altered. It's like extremely rare for that to happen, but it's usually innocuous with when you give cimetidine. Okay, so the bottom left picture is depicting the same thing, except it's going left, right? So hydrochloric acid getting released into the stomach chamber, and then we have a proton pump inhibitor is going to inhibit the direct production of hydrochloric acid, whereas your cimetidine is working over here, blocking the effects of histamine, right? And then we have, remember, ranitidine is gone, but also steroids. Steroids inhibit, they inhibit prostaglandin breakdown. And prostaglandins are actually protective. So these prostaglandins actually inhibit hydrochloric acid production. So if you take steroids, are you at risk for ulcers or not? You're at risk for ulcers because steroids stop the protective prostaglandins. Does that make sense? Prostaglandins inhibit hydrochloric acid. So if you give a steroid inhibits prostaglandin production. Okay, so steroids put you at risk for ulceration, right? Because for that reason. NSAIDs also work here. So NSAIDs, you can see over here on the bottom left, NSAIDs also are going to inhibit prostaglandin production, right? Prostaglandins are protective. They're good in the stomach. Okay, so therefore we're going to get a risk for ulceration with steroid use and with NSAID use, right? And NSAIDs themselves are directly toxic to the gastric lining as well. All right, so esophageal cancer. So Barrett's esophagus is from constant brashing of this acid, and eventually it can change the cellular structure, and it can become cancerous. So Barrett's esophagus can lead to cancer, right? So overview of esophageal cancer. So there's really no screening test you can do. If someone has GERD symptoms or they have alarm symptoms, that's when you would test for esophageal cancer. But there's no like specific test you can do. Kind of like with other tests, other cancers, you can say, oh, you have this on your lab test, you might have this cancer. Let's do some more testing. There's no specific test you can do for esophageal cancer, like blood-wise. They'd have to actually do an endoscope and look and see if it's there. Okay, so it develops the mucosal layer going outward. So here's the mucosal layer, and it's going outward, and it's occluding the esophagus, making it difficult to swallow. That's why one of your alarm symptoms is what? Progressive dysphagia, right? And eventually that's going to ulcerate. This is going to ulcerate that tissue, right? Cancer is not just a growth, it actually causes ulceration and bleeding. And they could have GI bleed as an alarm symptom, but also what else is an alarm symptom? Like make this, if it's ulcerated, what is it? Painful swallowing or ouchy swallowing or adenophagia, right? So ouchy swallowing. All right, so it's really asymptomatic until 50% of the lumen is blocked. So this is 50%, but looking at the whole 100%, that's, you got like 30% there left. So it's greater than 50% blockage, that's when you're starting to get symptoms. So obviously this is discovered early or late, do you think? It's discovered very late, all right? So if someone has esophageal cancer, I think I put it here, the 5-year survival, 5%. All right, that means 95% of patients die if they have esophageal cancer, okay? With early symptom, if the spread isn't done, if it hasn't spread throughout the whole body, then you can have a little better chance, but it's not great, okay? So what else do I want to say about this? So metastasis is the spread of a cancer through the whole body. It's called hematogenous spread, heme being blood, right? So to just spread through the body through the blood, because it's going to grow and grow and grow and grow, and then it's going to hit the blood vessel that is right next to it, right? And it's going to spread through the body. Okay, there are two types of esophageal cancer: the squamous cell and adenocarcinomas. The adenocarcinomas are the ones that are Barrett's esophagus. Okay, so those are the ones that we're talking about the GERD. If we're talking about the GERD pathway going from erosion of the esophagus to change in the cellular makeup, then to cancer, that's the adenocarcinoma. Okay, and that's in the lower 1/3 or the top 2/3, you think? It's right down here. The adenocarcinoma is that's all that stomach brashing up against the lower esophagus, right? It's really hard to brash up against the top 1/3, right? Sorry, top 2/3, right? So squamous cell carcinomas is just where it's not as common as the other guy. All right, so Barrett's esophagus, what is it? It's about 5% of GERD patients. As those cellular changes like we've been talking about, we've got the dysplasia down here. It's changing to stomach lining, and they do a little biopsy with what kind of device? With an EGD, okay? And then about a certain percentage, like there's a 1 in 1,000, will progress to esophageal cancer. So you should teach them some warning signs, right? If someone has Barrett's esophagus, they're getting EGDs more frequently than the average person, right? Every 3 to 5 years, I believe, right? 6 months to 5 years depends on how bad their dysplasia is and how bad their esophagus is. It could be every 6 months or it could be every 5 years, just depending. But either way, you want to teach them in that 5-year time to report what? Some odonophagia, dysphagia, some GI bleeding, right? Difficulty swallowing, ouchy swallowing, and what are some symptoms of GI bleed? Hematochezia, right? But it usually probably, unless there's a strong bleed, it wouldn't really cause hematochezia. It'd probably cause some melena, okay? All right, and then the other piece of that was unintended weight loss as well as an alarm symptom, right? All right, so squamous cell, I did say it wasn't as common, but sorry, I didn't say squamous cell is as common, but it is actually the most common one outside of Barrett's can develop, and we focused a lot on that, but actually squamous cell happens a little bit more. That's where it's not because of a ulceration, but it's because of other chronic inflammation, chronic damage, right? So you can notice obesity is in both categories, smoking is in both categories. That's really going to put them over the edge. But prolonged exposure, like achalasia means difficulty in the motility of your esophagus. Esophagus does not work like normal esophagi. Okay, so hot liquids, bleach, whoever's drinking bleach, that you're at risk for cancer. And then E2H, so alcohol consumption, puts you at high risk for squamous cell carcinomas. And this proto-oncogenes and tumor suppressor genes, we'll come back to this when we talk about oncology for exam 2, I believe. But basically, proto-oncogenes are genes that are like the green light. They are going to promote cellular growth and tumor growth. And when you have cells that are destroyed, those off switches and on switches get manipulated. So here we have increased amount of proto-oncogenes. These are going to increase cellular growth. And we're going to turn off the switch that suppresses growth. So we have more and more growth that occurs and more tumor development. Okay, this is showing alcohol and how it causes esophageal CA, liver CA, breast CA, colon CA. So drinking alcohol at this amount is not great, right? Was it greater than 13 ounces per day? Which had an 18-fold risk versus the normal person. Cancer. All right, so again, esophageal CA is asymptomatic until they might have alarm symptoms, right? So our alarm symptoms are going to be when you have 50% of your lumen occluded, and you have these, the GI bleed, the odonophagia, dysphagia, et cetera, right? So we recapped these here, okay? So what else? So what can happen if you have a tumor that's growing and growing and growing? It can then grow and ulcerate and into nearby organs. And what's just right in front of the esophagus? It's the trachea. It's called tracheoesophageal fistula. It can create a conduit there, and obviously that's going to cause some aspiration pneumonia and cause some problems, right? The other problem is that it can grow and grow and grow and spread into the bloodstream, right? And that's called metastasis. Right, so it metastasizes outward. It could go to the lung, which is nearby. And when you have metastasis to the lung, you usually have like pleural effusions. Looks like they come with a pneumonia, but it wasn't a bacterial infection. It was cancer, right? It can spread to the bone, and the bones have calcium, so you can get hypercalcemic from that. And it can spread to the liver. You get liver dysfunction. We'll talk about how to assess the liver function next week. All right, what else? So diagnostic tests, you can do barium swallow. You're going to see that there's a lack of flow right there, a narrowing. Right? They probably came to you because they have more than 50% narrowing of their lumen, so you're going to see that narrowing on the barium swallow as well. Right? They can do a EGD where they can biopsy it and they can stage it. Right? So staging is what's called TNM. That's tumor, node, and metastasis. It's like how big is the tumor, is there lymph node involvement or not, and is there metastasis or not. And whenever we study cancers, you don't have to know which one's which for which cancers. It's like, oh, for esophageal cancer, it's 2 centimeters. For esophageal cancer, sorry, for gastric cancer, it's 6 centimeters. You don't have to know that. All you have to know is that TNM is a way to stage cancers, right? And which one's the worst? When there's more tumor, there's more node, and there is metastasis. Metastasis is the worst part of cancer, all right? And that's always stage 4 cancer. Whenever you see someone say they had a stage 4 cancer, that means they have metastatic cancer, right? That means because stage 1, 2, and 3 are usually localized. It might be a little bit more spread locally, but it has not gone through the bloodstream and gone to different organs. When it goes to different organs, that's stage what? Stage 4 or metastasis. Metastatic esophageal CA can go to the bone, liver, lung, etc. Okay. So what else on this? So how do you know if it's spread? You can do a CT scan, or you can do an endoscope to look around to see if it's in the liver or not. But really, a PET scan is gonna light up the cells that use a lot of glucose. And what cells use a lot of glucose? The ones that have increased proto-oncogenes and decreased tumor-suppressing genes, right? That means everything's going overdrive. You have a lot of production of cells, and they're using a lot of glucose. And a PET scan is just not radio, but it's tagged glucose. I did say radioactive, didn't I? So it's tagged glucose, and you're going to pick that up on the PET scan where there's a lot of activity. Okay, and some tips and tricks for PET scan is don't eat other glucose, because otherwise that will get picked up. You want to have the glucose that you want to see on the PET scan. All right, so for 24 hours, they're going to have not a low carb, but a low carb diet, and they're going to have a no sugar diet for at least for 24 hours, right? And then they're going to be MPO the morning of, and they're going to get that PET scan. Okay, and what else? Costs about 22,000. I think it's rupees. I don't think it's actual dollars, but it's still expensive to get a PET scan. Like, why does everybody get a PET scan to see if they have cancer every 5 years? It's cost prohibitive. All right, so treatment for esophageal cancer. So chemotherapy, that's for the final, or before I think it's the final or the state exam too, I forget. But we'll talk about chemo and such later. All you have to know is that chemo is needed for esophageal cancer, especially when it's stage 4. All right, stage 4 cancer. And chemotherapy is going to go through the whole bloodstream, right? You can't do targeted chemo. Well, I guess I take that back. You can do targeted chemotherapy like brachytherapy and such. There's a little bit of radiology or radioactiveness or whatnot. But either way, it's IV form usually. There are PO versions, but it's IV, goes through the whole bloodstream and attacks things that are rapidly dividing. All right, that's how chemotherapy works in general. And we'll learn about the cell cycle for when we talk about chemotherapy. Anyways, if it's precancerous, you can try to resect it with an endoscope. We go in there and try to take out a little piece as much as we can. But if it's bigger, we might have to resect part of the esophagus, like with open surgery. We go in with surgery and we take out the piece that is cancerous, right? And then we have to sew it back together, otherwise it can't eat anymore, right? So we sew it back together, and we might even take out some of the stomach as well if it's spread pretty far. And it's going to connect directly to the duodenum or jejunum or ileum, right? Usually duodenum or jejunum, right? So that being said, we have no buffer, right? Usually it stays in the stomach for 2 to 4 hours, and then it will, as it needs to, squirt a little bit past the pylorus into the duodenum. But here, it doesn't. So you're at risk for what's called dumping syndrome. It just dumps all that bolus of food, just dumps into the intestines, and the intestines freak out because they're not used to a huge load of food. They're used to a small little thing that they can work on and secrete insulin to manage and secrete the enzymes to manage. So what you're going to get is a rapid absorption of glucose that causes hyperglycemia. Your S-test is going to freak out. They're going to get tachycardic flushed, and they're going to then all of a sudden they're going to get hypoglycemic because it's going to overreact, basically. All right. So dumping syndrome is a side effect whenever you are bypassing the stomach. So that can happen with esophageal CA. We talk about gastric cancer. That's also going to bypass that when we take out a piece of the stomach, right? You also see this with patients that have gastric resections for for obesity management. Okay. So going back to chemotherapy, just to point out that chemotherapy is for stage 4. Stage 3, 2, and 1, you can do radiation, you can do resections and such. And sometimes stage 4, you can also do some radiation and chemo. Okay. And there's something called adjuvant therapy. That's where you add things to chemo. There's different other drugs you can add to the mix to try to target specific genes and specific cell lines to mitigate the cancer, right? So stage 4 is where it has metastasized, right? So we can do surgery, we can do radiation and chemo, we can do targeted therapy, even immunotherapy, which is specific drugs that cost like $96,000 per treatment that are ridiculously out of reach currently. Okay.